Our next presenters are going to talk about behavioral support services across the Southwest LHIN. In Behavioural Supports Ontario, which sometimes is referred to as BSO. We're very pleased to have Bernie Blais here. Bernie Blais is my colleague. He's a LHIN CO in the North Simcoe Muskoka, and I've relied on Bernie quite a bit over my past number of years for assistance and advice. Bernie brings with him you can read his bio in the bulletin, but he brings with him a raft of experience, having been a CEO of the Chatham-Kent Healthcare Alliance, a deputy minister of Nunavut Territory, as well as a regional health authority CEO in Fort McMurray in northern Alberta. So great experience, and we're very lucky to have him as part of the LHIN team. We're also very lucky to have Dr. Lisa Van Bussel. Lisa is the chair of Western's Division of Geriatric Psychiatry, in addition to being the physician leader of the Geriatric Psychiatry Program at Regional Mental Health Care in London, and a psychiatrist for the Regional Psychiatric Program at Parkwood Hospital. They will speak of what is happening right here in the Southwest LHIN and the successes that we have had. They'll also talk about Behavioural Supports Ontario, or BSO, as a cultural change and a reinvention of the way that we care for this at-risk population. It's about dignity, respect, quality, patient-centered care. Now, before I pass it over to Bernie and Lisa, we're going to show a short video that was recently aired on Global TV.
So I wonder if any of you have seen this video. If you have, you just raise your hand if you've seen this before. So I think a few people have. I've got a few comments on the slide on the screens in front of you. I want you to take a few minutes and reflect on, what if we don't change this reality? What's the impact on our healthcare services and structures, on our hospitals and long-term care homes, in our community, in our neighborhoods, for our neighbors and friends and family? We all know somebody who has either been directly or indirectly affected by mental illness, dementia, or other neurological disorders that have resulted in a change in behavior, maybe a change in personality. And for many of us, this can become very personal. I work in this field professionally every day, and I know it affects many of you and your families. It certainly affected my family. And so if we continue to maintain the status quo, which after seeing this clip can be very distressing, I'm sure it's not only distressing for Derry and his wife, I'm sure it was very distressing for the hospital staff as well. I hear that feedback regularly in my work. I hear it from long-term care staff as well. So I would suggest that none of us want to perpetuate this current status for many of our frail older adults, in particular those who've really contributed to our communities and to our country. And so we need to look at maybe making some changes. And it takes a lot of risk to change how the healthcare service system works for our most high-risk and vulnerable people. And it's really starting to take those chances and start to change the system. And I think Mike already introduced that Behavioural Supports Ontario is one of those changes that are happening across the province. And I'm really pleased to be here with Bernie to co-present, as he's the project sponsor for the Provincial Behavioural Supports Ontario project. And I work in community outreach geriatric psychiatry, so I go to quite a few of the communities across the LHIN, doing outreach to nursing homes, residential homes, and going into people's communities. And I see day to day the struggles that family members have when their loved one has dementia that may have resulted in change of behavior. So before we proceed with the formal presentation, I'm wondering how many of you have heard about Behavioural Supports Ontario? Either through some education, great. So I see lots of hands going up. That's wonderful. How many have attended an information session or training session or some kind of webinar? I know provincially they've been doing them as well as through the LHIN for engagement. Great. And how many of you have been involved with some kind of committee or task group to help work across sectors and with community and hospital partners to help develop a system of change for the Southwest LHIN? Wonderful. We still have hands going up. And how many are you working in long-term care who've heard about this project, either provincially or locally, and have been involved in some way, directly or indirectly, in giving feedback to our LHIN in terms of moving this forward? Wonderful. And how many of you hopefully will want to hear more of this from Bernie and I? Great. So, anyway, in light of the clip that we just saw, and especially if those of you who follow the media, about the recently released report issued by the Long-Term Care Task Force on Resident Care and Safety, there's perhaps no better time to talk about Behavioural Supports Ontario and what's happening within our LHIN and provincially. We know that there's ever-present need to improve the lives of elderly, and specifically older adults who exhibit responsive behaviors. And that can mean many things. It can mean wandering and agitation. It can mean aggression, such as swearing or pushing or resisting care. And this can be associated with older adults with dementia, mental health and addictions, and various neurological disorders. So our objective today is to provide you with both the local and provincial overviews of the strategies developed to improve the daily lives of these people, their families and caregivers. I think that means most of us in the room. So in essence, we're going to talk about positive, meaningful, person-centered care and change. I'm going to have to remember to use the clicker, Bernie. So the agenda is going to we just talked about the changing reality. I'll talk about the local perspective for the Southwest LHIN and the work that's been happening over a number of years. And Bernie's going to talk about the provincial picture, the Behavioural Supports Ontario, a recipe for success, and focusing our progress on better health, better care, and better value. And at the end, we'll have time for questions. So let's talk about some local information. But to take a step back, we know that there's a significant demographic change happening. I think many of you must have seen in the local media, the newspapers, etc., the Census Canada data that was just released from 2011. So we know right now across Canada there's about 6,000 adults over the age of 100. In about 50 years, in 2061, there should be about 80,000 people over the age of 100. So we know that the demographics are shifting. In Ontario in particular, we're going to continue to have similar demographics to what's on the slide. For the Southwest LHIN, by 2021, about 20% will be over the age of 65, and about 43% will be over the age of 75. So we know that our region has a slightly older population, and that makes sense. We know that in the urban hubs, populations tend to be a bit younger, and then as we get into smaller communities, it tends to get older. So those of you from Owen Sound, Grey Bruce, here in Perth, you see that every day in your communities. We know seniors suffer from an array of mental illnesses, including mood and anxiety, psychotic disorders, addictions, and they know they have emotional and behavioral cognitive complications of a variety of brain diseases, such as Alzheimer's, Parkinson's, and strokes. The Mental Health Commission of Canada, Seniors Advisory Group, has helped us delineate this further in 4 groups. In particular, those who are aging with severe mental illness, such as schizophrenia, bipolar, depression. It may be mild to very severe. Those who've developed dementia later in life who have behavioral changes, which can occur in 90% of people who have dementia. And those who develop late life, late onset mental health and addiction problems, particular mood and anxiety disorders. And the final group, which many of you who are working in acute care hospital sectors see an aging population with chronic, complex medical problems who can currently have some change of their mood or mental illness. So the Aging at Home project locally in the Southwest LHIN was hopefully following this demographic change, as well as looking at the information from local as well provincial and national strategies. This includes the Rising Tide document from 2010 from the Alzheimer's Society of Canada, as well as some of the information coming from provincial strategies. In particular, there was a behavioral think tank looking at the need for behavioral assessment units across the province. That was the early beginnings of Behavioural Supports Ontario, in particular, pulled together by Ken Dean, one of the ADMs for the Ministry of Health. And at that time, the feedback was very strong that not only did we need to look at changes in service sector, we needed a system of care. And that first think tank actually brought the lived experience of family members of individuals who had dementia and behavioral changes. In the fall of 2009, over 30 partners from across the LHIN were challenged to submit a business case to describe what a coordinated system of care for seniors with behavioral challenges would look like. And they looked at meeting 3 objectives: improving the health of this population, enhancing the care experience, in particular quality, access, and reliability, and trying to reduce the costs. In particular, where services were in place to assist long-term care homes in the care of these types of residents, it was evidence that the service capacity could not meet their increasing levels of need, in particular because of increased risk and complexity of these individuals. In spite of the efforts of dedicated healthcare professionals, a fragmented system of service structure had developed over time. In some cases, it was not the absence of services, but it was rather the challenge in terms of lack of coordination, integration, and accountability. In other situations, it was just lack of access to services. There was gaps in certain communities. So from this group that came together, there were several themes that emerged. Clearly, greater system integration needed to occur. There had to be local accountability and engagement across care partners. It needed to be meaningful for the person, their families, and caregivers. And we needed to continue to move from practice to action to bring the best evidence forward at this time. And the LHIN-wide collaboration and coordination needed to occur. And capacity building and education would be a forefront in helping to move all of our communities ahead in dealing and supporting these individuals. There were 2 fundamental documents that the Ministry of Health had published over the last several years that were important in bringing together this information and using best practice. It was the Specialized Geriatric Mental Health Outreach Team's Program Policy and Accountability Framework, as well as Building a Better System, Caring for Older Adults with Aggressive Behaviors in Long-Term Care. And from that business case came a case of change imperatives, including better tools and information resources to be used, promoting capacity and resilience of aging individuals, improving system navigation, responding to diverse needs and resources of the community, enhancing community capacity, recognition of the uniqueness of each person and their life experience, strengthening community awareness and responsiveness, and ensuring evidence-based performance results. So these are a few quotes that sometimes I use when I'm teaching students, and what I'm hoping is that these quotes become obsolete when we speak about older adults who have behavioral changes. I see that there has been a shift, and that with this project and the committee that was pulled together in 2009, we've seen a positive solution-focused philosophy which brings partners together from all sectors, CCAC, Alzheimer's societies, local hospitals, specialized regional resources, day programs, community mental health services, in a purposeful way. And since starting this work together, there's been a synergy in developing and improving care for older adults. I know we had the video clip at the beginning and we saw the crying baby, and we often hear of the quote, "It takes a village to raise a child." I think what we've learned is it takes a coordinated, committed healthcare system to support an individual suffering from dementia. Behavioral support systems, when we had the funding from 2010 and 2011 through the Aging at Home, was a real opportunity to leverage new and existing resources. So in essence, what occurred in terms of the business plan was to ensure that there was LHIN-wide coordination, for example, a project lead and evaluation, that across our area there would be hubs of teams affiliated with the hospital, but meant to work and liaise with community and long-term care. Some of these teams were currently in existence, but needed increased resources and support, and they're teams that had to be created to deal with significant service gaps. Also, there was enhanced psychogeriatric resource consultants who were hired and trained to work as a role in terms of education and capacity building. And this is a provincial standard that helps the Southwest LHIN move ahead in terms of engaging the community and capacity building. An important added function was the OTN, which was partnered with right from the beginning in terms of the steering committee. and important in terms of working together with all partners, in particular long-term care, to make technology accessible across the LHIN. The business case included the following important areas: that we defined the target population, there was clear entry and access criteria, that care provision, coordination, and assessment was consistent across the LHIN, that linkages, in particular across care partners, as I mentioned earlier, were established. And thus, each area had cooperatives established to provide this function. There was an accountability and governance system and information management. So really, and we heard this earlier today, we moved to include a top-down and bottom-up organizational structure. In particular, the geriatric cooperatives were formed to provide local advisory group to help monitor the status of the project and work with community partners to solve problems. So this is another cartoon to just show that we stopped going down the stairs and bumping our heads on the steps. We took some time to reflect and pulled together a system of care. We also focused on learning from within and learning from outside. In particular, ensuring that education and capacity building was person and caregiver driven and directed, involving collaboration with the person, the family, the health team, and service partners, and enabling solution finding and emphasizing prevention and early detection. Acknowledging the collaboration is important, in particular respecting the unique knowledge of each care participant. Here's quickly a picture of the organizational structure which we can provide for those of you who are interested in understanding who your local leads are in this project. As we were working through the implementation of the Behavioural Support Systems Aging at Home project, the opportunity to work with the Behavioural Supports Ontario project occurred in late 2011, in particular when the Minister of Health announced $40 million going across the province. The Southwest LHIN had $3 million allocated to it. In particular, this reinforced the already established system integration, in particular the project-wide lead, having LHIN-wide evaluation and QI resources. With the mobile teams that were established from the first project, there would be long-term care resources attached to teams through a purchase service agreement. And we would round out the further funding to ensure that community agencies, and particularly Alzheimer's societies, had enriched social work services and increased adult respite programs. So I'm going through the last few slides quickly. Thanks, Christine. We had a few important quality improvement strategies, in particular in the fall of 2011, a value stream mapping session, which worked directly with individuals who had their own lived experience of their family member with dementia and behavioral changes. And from that, we had a value statement saying, as mentioned on the slides shown above. These important quality improvement initiatives are about improving the system, not making it perfect. And finally, we have had a great engagement with the OTN in terms of having over 38 of our 78 homes having OTN units and installed. And actually next week we'll have a clinical telemedicine workshops developing theoretical concepts and ensuring resource and clinical tools and practical techniques to working with OTN. So where are we going? We know that there's been tremendous change in terms of working with service partners across the system. So we need to further work around change management strategies, working to improve access to care and transitions of care. And I think the situation we saw in the video is a really important one, where our teams are striving to work to make transitions in care more seamless for individuals and their families. Engaging in supporting primary care, which is very important as we move forward. Communication, and focusing on person-centered, team-based service learning, so working and training each other side by side. This is a summary slide of the Behavioural Supports Ontario, so as I transition over to Bernie, it's a reminder of the pillars that ground us: is system management, interdisciplinary, collaborative, cross-sectional care, as well as capacity building. And my final slide is for all of us to work towards having successful aging for all of our population, in particular frail older adults who can still have a sense of personal fulfillment in the context of illness and disability. Now I'll move over to Bernie. Thanks.
Well, good morning, everyone. So I'm here to pep you up, hopefully, and get you to lunch. So I just want to thank Lisa. Lisa's been an incredible champion for this project, I think both locally and at a provincial level. And if I had a chance, I would steal her somehow, but I know she's committed to this area. So you should be very proud to have a person like this in your Lynn. Let's see where we go here. I got to use my left hand. Okay. This is a slide that's been with me for a long time. The best way to predict the future is to invent it ourselves. The one thing I can tell you about the Behavioural Support Ontario initiative is that we have enough knowledge in the province to actually change, transform in this area. We have enough passionate people, champions, and I think what we can say about BSO is the people that are at the table moving this forward are incredible individuals. I'm so proud to be part of that team, even though I may not have the degree of expertise, but I bring leadership, system leadership expertise. So I have to tell you, we have a great group of people that are committing a lot of volunteer time to make this happen across the province. So the other thing I want to mention, and we had our symposium yesterday, so I'm going from one, spent all the day there, and came here last night to your symposium, and there's lots of similarities. But the one thing I want to tell you is that we are in engagement fatigue in our system. And the danger of that when we engage people is that we don't do anything but the knowledge that we get from them. So the idea that BSO has brought to the table is that everything that we hear in all of the forums that we've organized, and we're turning that into action. So they need to see something real happen. And so we have three things that we say. So be real today, because if you're not real, you don't present the real things that we have to talk about, there won't be a very good outcome. And I know you're all committed because you're here. Be revolutionary. It took millions of years for the dinosaurs to go away. So we don't have millions of years. We have very short timelines to be able to achieve this goal. So be revolutionary. And these are the words that we use in our Lynn all the time. And be courageous, because it's not enough to have a good plan to talk about it. You have to implement something. And you have to do it in a way that makes sense. So have courageous conversation. And when you speak your perspective, at times, I know that historically sometimes you get shut down in a meeting, or you say that's stupid, or these comments that come along, or you make expressions. The fact is that we have to speak our truth, what is true for us, and especially when we're dealing with this patient population. Because if we don't hear what people have to say and we do something with that, then nothing happens. So have courageous conversation and be respectful, and don't be afraid to give your perspective, because out of all the perspective, I can tell you magic happened. At our forum yesterday, magic happens. So when we work together, things get done better. Now, the provincial picture is changing. So from our perspective, I think what's made this project unique and the buy-in that we've received is quality is job one. That's what we started from. I remember talking to the ministry, said we're not starting any project unless it's all about quality. So if it's about saving dollars, that doesn't sell well. But if we can demonstrate that quality is important and we work at it from that end, the people out there are caring and compassionate. They're going to buy into that. They're going to come with us on their journey, and we're going to get something done at the end of the day. And so that's where we landed, and that's where we've been, and that's where we still are at today. So now, I think Lisa's kind of talked to this slide anyway, because it's a very similar scenario as it relates to your local project. But to date, there's about 300 frontline staff have been recruited, and we're looking at about 600 staff by the time we're finished with the project. We have trained 4,000 people since November. We just had a meeting with four ADMs, and the chief nursing officer. They're saying, well, how did you do this? How did you manage to harness and be able to deliver this kind of objective? And so now we're looking at maybe 8,000 people by the end of December in areas where we need people to have this expertise on the ground in all aspects of what we do. And remarkably, the physician sessions that we have held in our Lynn have been full, and we have a waiting list for people who want to come to these sessions. And that's a remarkable outcome. So I'm not overstating it. It's actually the reality of what we're doing. When was the last time we were able to train 4,000 people in a very short period of time and fill the rooms 100%? And the big thing was for us is to really the principle for cultural and systemic change in the way that we could mobilize the imagination of the people at the table. I want to reinforce that this is about a cultural revolution. Culture eats process for breakfast all the time. And if we don't build relationship and trust and anchor it there as much as we can, then we can't really deliver on anything. So it's a cultural change that we're putting in place, and I think behavioral is attempting to drive that kind of direction. So change management is fundamental in what we're doing right now. Slide 27, what we've done is, again, the quality issue, we've grounded it in the Health Quality Ontario 9 attributes of quality. And this has been basically the foundation by which all of our discussion, all of our thinking, all of our knowledge transfer occurs. I guess it's slide 28. So we know we have to change and we want to change. It's about building trust and relationship. One might suggest that it starts with fostering strong, meaningful relationships in our partnership, but the importance of having committed and passionate individuals leading this project is the key. I think we said earlier that leadership is the most important element. If you don't have that, you don't really get started very far. And the idea is that we also have to demonstrate results. If we want people to follow us or be part of this, as we go, we have to continue to be changing our story. So when we started, it was all about take a chance with us on this journey. And then a little while after, we started demonstrating some results. And now we're pulling all these stories together for the minister and others. And hopefully at the end of the day, when we finish this journey, we're going to have an evaluation done of the 4 early adopters, which I'll talk about in a minute, that's going to demonstrate the beginning of a journey that's going to demonstrate significant result over the next 3 to 5 years. Slide 29, we need to learn how to do things differently through a coordinated pan-LIN approach. Remember, the NSM LIN is the lead LIN. We're responsible for the accountability agreements and to make sure that we're moving forward on, we have reporting as well throughout this process. So we take big ownership of that, but our partners, I think, have been phenomenal. The level of commitment the CEOs, LIN CEOs has made to this project is the best I've ever seen in my entire career. So again, when you have this kind of support, you can actually make significant difference. But I want to make sure you understand, this is one project with 14 LINs. One project, 14 LINs, not 14 individual LINs, one project. Because at the end of the day, what I'm going to explain to you in a minute, the knowledge exchange and the buddy LIN system transfers knowledge across the system in a very rapid way. So if we didn't work as one project, we would not be doing that. We would be keeping our knowledge in our individual LIN, and nothing would get exchanged across the province. So one project, 14 LINs, okay? So keep that in mind. I'm going to go to this slide. I think maybe I can explain it better. I was going to use a pointer, but I can't do it. But at the end of the day, this is really the heart and soul of BSO, how we drive the whole transformation. At the top is the coordinating and reporting office, and that's the role that NSM LIN plays. So we have accepted to be the main drivers of the whole process, the whole system. So that's our role. We have accountability agreements. Also, we provide reports on a regular basis, quarterly, to the minister. And then we also monitor through a project management office the whole system and where everybody's at any given day, whether it's the hiring of employees, where they're at with their planning implementation. The part below that is the 4 early adopter steering committee, and I'll come to that when I show you the other slide. And then also the local LIN project team supported by quality improvement teams. And in each of our LIN, every LIN now has a quality improvement facilitator that's been trained by Health Quality Ontario, an incredible partner that has delivered more than I would have ever expected on this project. They have been just this unique group of people that have dedicated nearly 4 people to work with us on this particular project, and that now have told us that they're going to put the same amount of resources in year 2, which is a great news for us. At the bottom is the 4 early adopter lens. Now, how many of you have been in a pilot project? Raise your hand. Pilot projects, right? I hate pilot projects, okay? It's not because they don't achieve outcomes. It's typically, when you do a pilot project, the knowledge stays only within the pilot. There's no way, there's been no process to exchange that information on an ongoing basis with others. So the early adopter LIN had to sign an agreement that they would adopt 2 or 3 other LINs, and their job, as the early adopter LINs are more advanced, to transfer that knowledge, do rapid knowledge transfer to their buddy LINs. And therefore, by November, the next round of 10 LINs launch, they're not starting at ground zero where we started. They're starting now with a much more advanced knowledge of what the lessons learned and the experiences that we've had, rather than starting at ground zero. And so if we had more LINs, then we could do the same thing. So the whole idea of knowledge transfer becomes critical. We don't do that well, I have to say, in any province I've worked, which is many. And then I'll show you this slide now turned upside down. So you can see the early adopter LINs on the second bar, and how each of them have 2 or 3 LINs that they're responsible to bring along on the BSO journey, the learning journey, knowledge transfer journey. And this is basically how it's worked. There is a steering committee of the 4 early adopter LINs, and basically as well, every week they've been meeting, they're meeting every 2 weeks to transfer more knowledge and create these exchanges of information at a system level and at an individual local level. And then you have the quality improvement teams which are in place in all of our LINs, as well as the provincial resource team, which is our expert panel, by the way. The chair of that is Dr. Ken LeClaire from Providence and the Eastern Township or Kingston area. And so they play a critical role. And at the other end, Health Quality Ontario, what's missing on this slide that I wasn't allowed to put on is the Ministry of Health. The Ministry of Health, in my experience, and I was a deputy at one time, and we're not always great at responding. It may take a year or 2 before we get back to you. This has been one project where I have to give them kudos. They have been unbelievable. They have a team assigned to this, the BSO, and in the first 4 months of any major project, the chances of failure are very high. So you have to have issues management, so you're dealing with issues. If you can't get them resolved, your project dies very quickly, not a slow death, a quick death. And so the Ministry of Health had to play a pivotal role in mitigating all of the things that came up. And within days, not months, not years, they were able to solve most of the things that came up that we needed to solve, and also with Health Quality Ontario and our other partners. So this is the heart and soul, I guess, of the BSO. Now, this is slide 32. This is at a provincial level. The value stream analysis examined, I didn't know much about value stream mapping, and also Kaizen event. Kaizen means change for the better. And all of the knowledge exchange that we had with the Alzheimer's Knowledge Exchange Network. And now I know a lot more than I ever did. But this is kind of like a picture of how that works, the provincial picture at a system level on how we're doing this whole issue of value stream analysis. And now that's being done within each LIN, because they've all been trained. We're doing, I forget how many more sessions in the next month or so across the province. And so now they've become experts, I think, at doing their own thing. Now, this one here at a provincial picture, it gives you a glance of all of the different projects that are, so some have decided they're going to focus their resources on primary care as an example. So trying to improve primary care in regards to behavioral. Others are doing centralized intake, such as North Simcoe Muskoka. Mobile teams are prevalent all over the place. So Kaizen events have helped develop the essence of what a Kaizen team should look like, or a behavioral support unit. So this is where we're at right now in each of the LHINs in terms of what they're accountable to do by the end of December of this year. This primary care collaborative toolkit was created by Hamilton Niagara Haldeman Brand. So I have always a hard time with that one. It's a mouthful, let's put it that way, for a French Canadian. But at the end of the day, if you haven't seen this toolkit, grab it. It's phenomenal. It's a fantastic toolkit. And this is, again, the modeling of the pathways for a patient displaying behavioral changes. And now we're using this mapping across the province to help each LHIN do a better job of organizing that. We have the provincial system intake through, though led by North Simcoe Muskoka and Southeast LHIN, respectively, there is a natural linkage between centralized intake and mobile and support team, collaborative working groups. And Central East evolved from a mobile support team, as an example, to an integrated team, so to their next generation of strategies already, and also actively developing and testing elements to meet their local context, given the inclusion of a transitional behavior unit in their action plan. So we started thinking this big, and now we're already at this level. So we're surpassing a lot of what we had anticipated already on this particular initiative. Slide 37, sorry, the provincial picture, this is just the framework that was developed that we're basically testing right now across the province, and it has basically 3 components that are critical: system coordination, interdisciplinary delivery teams, and also knowledgeable care teams and capacity building. This slide just basically depicts it in a different way. This is the continuation of that, always looking at knowledge exchange, funding and resources, and quality. So what this emphasizes is that our project is grounded throughout 100% by quality. Everything we do, our training, all of our value stream mapping, our Kaizen events, all of our knowledge transfer days, it's all about grounding it in quality. Now, this is my final slide. Mary, her name and photo have been changed to protect confidentiality, has been a resident of Ontario for her entire life. And this is a true story, by the way. This is Hamilton Niagara Alderman Brandt. Did I get that right? She was a school teacher, and recently she was admitted to a long-term care home in our province because of her dementia and difficult behaviors. The long-term care staff had an increasing difficulty dealing with Mary's personal care. They have tried a number of different medications, and every day they contemplate sending Mary to the emergency department because they just can't cope with her behaviors anymore. CCAC is aware of Mary's situation, is also aware of the new BSO project, and specifically about the long-term mobile teams. These are new long-term care mobile teams that is currently in development stages. CCAC identifies Mary's situation to the newly formed long-term care mobile team. The mobile team connects with the long-term care home to determine if there is anything at all they can do to assist in Mary's case. The long-term care home is very skeptical and initially suggests that they think that they are fine. They state that they are compliant with all the regulations and articulate they don't need anyone to come to assist them with this resident. After some encouragement from both the mobile team and the CCAC, and you have to be persistent, the long-term care home agrees to allow a mobile team to come and observe Mary and her care. The mobile team arrives and they observe long-term care home staff interacting with Mary. And the observation that we mentioned earlier, this is basically exactly what you were referring to. The long-term care home staff are trying very hard to do their best that they can for Mary, but she is very combative. The staff become frustrated, and more frustrated the staff become, the more aggressive Mary becomes. Eventually, the staff stop trying and depart the room. The long-term care mobile team asked the staff if they could try to provide care to Mary. Surprisingly, the long-term care staff, Mary responds well to the mobile team and starts assisting with her personal care. So it is no longer a fight to provide care, but instead an enjoyable and therapeutic interaction. At the end of the interaction, Mary is relaxed and comfortable. She is looking forward to her day. The long-term care home is overjoyed because they saw a very different side of Mary. Over the next several days, the long-term care staff attempt to implement some of the strategies that were shared with them by the mobile team. They find the strategies very helpful, and Mary's response is improving. They no longer are worried about Mary will have to go to the emergency department. Not to say that she might not have to go eventually, but right now things are really improving. So I'm going to close to some extent. What are the three outcomes of this story? Staff in their home are better trained and more confident to treat Mary and people like her. The system has avoided a transfer to acute care and reduced or delayed the risk for future transfers. And most importantly of all, Mary's getting better. So that's the moral of this story, I guess, and that's what BSO is all about. Anyway, thank you very much. Oh, sorry. I just wanted to put this last slide up. Better healthcare, better value, but smiling is infectious, and so is BSO. If you can consider, we have thousands of people mobilized working on this issue. So what's special about this project? I think it's because we have grounded it in quality and training. And we have a great team of people, and all the LHINs have committed to implementing this project in the hope of improving behavioral support for patients that require that service. So thank you.
So we have about 10 minutes for questions for either Bernie or Lisa. So please feel free to come to one of the microphones, and they'd be happy to answer your questions about BSO. Everyone's rushing up. We may have a problem here.
Everybody wants to go for lunch, Mike.
I'll start off, and Bernie and Lisa have been joined by Matt Snyder, and Matt is the project manager with BSO and has been instrumental in moving this initiative along. I'll start off then with a question for Lisa and Bernie. Lisa, you talked about the process having to be meaningful for the person, for the family, and for caregivers. Tell us how you actually solicited that information back from the patients, from the families, and the caregivers to put it into practice.
In terms of, just to clarify, you mean in terms of the development of the framework?
That's correct.
Actually, within our LHIN, we took several opportunities, and I think in particular, taking the signal from the Behavioural Supports Ontario project, we had several people who had family members who had dementia and behavioural changes who participated in the fall in November with our, what we called the value stream mapping session, who gave some very clear feedback in terms of their experience of our healthcare system, and really were able to describe their emotions, as we heard Lynn say, and give us some really clear feedback. I can give you an example, Mike, that's really telling that I think is really challenging for all of us. I work in the community, but I'm affiliated with the hospital, and for many family members, when they're really stressed and after caregiving for often months or years, feeling that they're on call 24 hours a day, 7 days a week, they bring their family member to the emergency department, which is not uncommon for our region and across the province prior to this. And the concept that they feel that they are being labeled as dumping their family member was really one of the messages we heard loud and clear. So we wanted to help try to understand that perspective and how to reframe it for them so that, you know, they may feel that they're in crisis and they may need to go somewhere to get support. And how can we make sure that the care providers that hopefully they're linking with in the system that we're trying to develop and evolve understand some of those perspectives, especially when they're in a crisis or very frustrated with the care that they have to provide. And so I think that was one really clear example. This March, we also had an opportunity to bring care providers, direct care providers across specialized services, CCAC, and some of the teams that are developing. And we again brought an individual with her own lived experience of mental illness in late life, as well as a family member. And they shared their story in a large group, not quite as large as this. And then from that, we took some time to reflect on the meaning of those stories and how we as care providers could maybe do things differently. So those were a couple of opportunities that we really took And again, from the provincial project, took that signal, and we were encouraged and nudged to really try to embed that more and more into the work that we're doing. So I don't know if that...
Great. No, that's a great response. I think we have a question here.
Thanks. My name is Neville Suskin. I'm a cardiologist whose main role is in cardiac rehab and secondary prevention. But in my daytime job that provides remuneration, I'm an acute care cardiologist, and I'm currently on service at one of the facilities. I have someone covering for me. And I just did a quick count of my patient census while I was here, and over 50% of my patients are over 80 years of age. And a number of them have behavioral issues that have been demonstrated over the past 2 weeks. I'm not sure whether they're greater than the patients who are younger than 80 or amongst the staff, but nevertheless, they have behavioral issues. And I'm wondering, with the BSO initiative, whether that has any implications for us as healthcare professionals linking our patients with better care directly in the acute care facility, or is it providing the other healthcare professionals in our facility who deal with these things with better resources, or is it something we should be more concerned about at discharge?
I'll give it a try. The answer is yes. I think that our focus is really initially was to build on existing, and one of the things that we realized early is that we need to do a current state analysis of what already is there, and then begin to look at what are the gaps in services and make it a program across our various local communities. And the idea is to also, the whole navigation aspect is critical. I think part of what you're alluding to is how do we get those referrals to the right place? And so I think that's what we're working on, and hopefully by the end of this year, this calendar year, we'll be able to provide you more evidence as to what our aspirations are right now, what we're working on has actually been achieved. But we're already, anecdotally, the stories that are coming in from various LHINs are already demonstrating that is occurring. So hopefully we're going to see much more of that happening within the next 6 months as well. So maybe, Lisa, do you want to comment?
And I'll try to respond from the Southwest perspective, and I have many colleagues in the room who could maybe give more specific details. I appreciate that, especially in acute care. My clinical work is not necessarily hubbed in acute care. I know that what we're already seeing, some early signals across the LHIN, that as the teams are up and running, that they get their own education and capacity and their skill sets are solidified, that we're starting to see some movement. I'm just saying this very gently in some areas where there's been some ALC hubs. I've heard that from a couple of jurisdictions, so that's really good early signals. What we're also seeing is as the new hires are starting to get trained, the opportunity to do capacity building or education across sectors would really be important. I know I was talking with somebody from the St. Thomas area in particular about some of the changes they're going through, and will there be opportunity to provide education to some of their emergency staff or hospital staff, and that would absolutely be the goal as we start to get more of our staff on board. In particular, the BSO project, the provincial project, many of the new hires will be focusing mainly on long-term care. That's been the funding parameters that we've been given. But we think that when that starts to settle down, we will have our other teams work together to focus on some of the other areas and pressure points. So I think that's the change that we're hoping to start to see happen. Without having the numbers in terms of the evaluation, I've certainly heard that from a couple of hospitals in particular where they've been able to do some complex case rounds, bringing CCAC together with some of the mobile teams with this expertise to see how can we get this person home more effectively and hopefully stay at home rather than coming back to the emergency or hospitalization again. So those are some of the stories that we've been hearing across the RLIN as well, and hoping that we'll start to see more of the impact over the next year. And again, Bernie's LHIN is one of those early adopter LHINs, so they're ahead of us in terms of their hiring schedule. We're hoping that we'll get some more dividends coming up fairly soon. I think that's maybe where we're just off the timeline from, say, North Simcoe, Muskoka LHIN. I don't know if that's...
Thank you. I think that was helpful. Just a follow-up question in terms of evaluation of the BSO's impact or effectiveness. I wonder what parameters are being used to determine its effectiveness. Thank you.
Yeah, I can speak to that. So the evaluation is formally an evaluation of the service redesign outcomes in the 4 early adopter LHINs. To frame our analysis of what we've achieved, what's happening, we're referring to those 3 pillars. You saw them on one of Bernie's slides towards the end, the idea of interdisciplinary care team, the capacity building. Those 3 pillars are the objectives for the project. We want growth in those 3 distinct areas, where we want enhanced service from those 3 perspectives, and we're evaluating the outcomes against that standard. We can talk offline about some of the details about the evaluation. You won't be surprised to hear it's quite complicated, but at the macro level, that's what we're talking about. We're trying to see how close we can get to those 3 objectives that were identified in an earlier phase of the project, when we determined that this framework is where the system needs to be.
Can you hear me? No, okay. I just want to add as well, if you go back not too long ago, we had the Aging at Home initiative. And I know that we did some good with that across the province. But there was never an evaluation process built into it. So we don't really know what the full outcome of that expenditure, I think it was $780 million. And so in this project, we felt it was very important to be able to evaluate at least the impact using the framework as our key driver for that evaluation. And I think that what we have done well, we involved McMaster to help develop the RFP before we sent that out to the marketplace as well. So we think we've got it pretty well right. The fact is that a lot of what we do never gets evaluated. We don't know, well, we feel good about it, yeah, but we don't know whether what success looks like. And I think, I'm hoping, I guess, this is going to be the truth at the end of the year, that at least the fact that we've grounded that, it's a very expensive evaluation, the fact that we're going to evaluate the 4 early adopters will give us evidence and the ability to continue to tweak it or make major changes to it, and that's what we want. And the other thing is, when in BSO 1, the first year when we developed the framework, we found that the information that we needed, for the most part, was not available. So the indicators that we thought would be there and the kinds of information we needed was simply very dismal. It wasn't really well captured. And so part of what we're doing now is we've developed a series of indicators that we think are the appropriate one, and then hopefully we'll be able to advise policy advice to the ministry to ensure that we enshrine that, entrench that across the province. I think the behavioral issue is much bigger than what the data indicates, but I don't know that because the data is not that great. And so once we get the data cleaned up, this is another opportunity for us to really begin to measure how big is the challenge and then get ahead of it and then be able to measure whether what we're doing is having a true impact. And if it's not, change course. And so I think one of the success stories I'm hoping is the evaluation piece.
Great. Any other questions? So thank you, Dr. Susskind, for those questions. On behalf of the Southwest Lynn, I'd like to thank Lisa and Bernie for their leadership in advancing this initiative. Again, it's an example of where people are going above and beyond their regular call of duty and their regular business to do something that benefits the system. So again, thank you for your strong leadership. And if you can join me in thanking Bernie, Lisa, and Matt.